My dear students, in this video, I'm going to touch upon on few aspects of ARDS ventilation in 2025, some of the emerging concepts. Uh, we know that there was once a famous psychologist, Abraham Maslow, who said that the emerge in the needs of hierarchy, the emerging things are always which begins at the ending of someone. So wherever there are some concepts which are emerging, it means that something else is ending, and therefore these new concepts are slowly taking over those ones. So in ARDS ventilation also there are a lot of concepts which had provided us a good support in the previous years, but they are gradually getting replaced, and that is based on the needs of hierarchy. Let us start with a case. A 45-year-old female who has a BMI of 36 is admitted with viral pneumonia and moderate ARDS with a PF ratio of 120. Patient is on volume control ventilation with a lung protective ventilation with a tidal volume of 6 mL per kg of predicted body weight, an FiO2 of 0.6, PEEP of 10, with a plateau limit set at 30 centimeter of water, and a static compliances of 24 mils per centimeter of water. Now, the problem is despite optimal sedation, the oxygenation is suboptimal. So probably we would think about increasing the PEEP, but should we increase the PEEP or not? Or PEEP titration is based on a lot of factors. And we know that just as the increase in PEEP can cause a recruitment of the collapsed alveoli, it can also cause overdistension of the normal alveoli, which might be harmful. So one such emerging concept to help in the application of PEEP is the electrical impedance tomography. And electrical impedance tomography is a non-invasive imaging technique that uses electrodes on a body surface, just like ECG electrodes, to inject a low frequency electrical current and measure the resulting voltage. So once we know that voltage, then an image is reconstructed, as you can see on your left of the screen, which is initially crude, which shows the internal distribution of the electrical conductivity, and that can reveal some changes in the impedance in the tissues. And we get different types of images, and these images are reconstructed to inform, as you can see on the right, the EIT images with the ventilated areas showing high impedance changes and collapsed or even over-distended areas showing low impedance changes. And therefore, it is exactly possible to understand that which part is being ventilated and which part is getting collapsed. So this helps us to avoid blindly increasing or decreasing the PEEP, and it keeps a check on either increasing the PEEP to an extent that it is not going to cause any harm. Now, how to step-by-step PEEP titration can be done using this electrical impedance tomography. One, we have to record the baseline EIT at whatever PEEP level we are measuring, observe the ventilation distribution, which likely shows a dorsal collapse and a ventral overdistension. And then, just like any other PEEP titration method, we increase PEEP in steps of, say, 2 centimeter of water every 2 to 3 minutes up to our preferred set limit of, say, 20 to 22 centimeter of water, record the EIT changes at each step, and identify when the dorsal regions begin to reopen. And that is where the increase in the regional ventilation. And then we go for a decremental phase where we decrease the PEEP stepwise in 2 centimeter water decrements and observe when the dorsal ventilation starts to fall again. So the PEEP just before this loss is the optimal PEEP, which is the best compromise. Or in terms of quantitative output, it gives us three things. One is the overdistension percentage, two is the collapse percentage, and third is the global inhomogeneity index. So these are technically the three parameters which are calculated by the electrical impedance tomography. And as you see on the screen, that we are plotting this both versus the PEEP. In the graph, you can see that there is hyperdistension on this blue lines and the collapse. So at the junction between the two, we get something which is optimal, and overdistension occurs with higher PEEP, collapse increases with lower PEEP, and this junction, which is the optimal PEEP, is the intersection point of the two curves. So that is how we can, based upon the EIT images, we can choose the optimal PEEP. Now, if we interpret in terms of our cases, suppose we gradually increase from 8 to 10 to 12, and we see that the percentage of collapse, and look also into the percentage of overdistension, as we can see, as we increase the PEEP, the percentage of collapse is increasing, as well as the overdistension is increasing. So percentage of collapse is decreasing, I mean, sorry. And we also keeping an eye on the compliance. So at 14 PEEP, we can see that the percentage of collapse is 10%, the overdistension is 12%, and the compliance is best, which is 33. And if we increase it beyond 14, the percentage of collapse increases, but then again, the overdistension starts increasing and the compliance falls. So we know that a PEEP of 14 is probably the best. So this is how we have to interpret the EIT, whether there is significant dorsal collapse, partially collapsed, better aeration, optimal balance, and the beginning of overdistension. So here we can identify 14 centimeter water as the optimal PEEP, which improves the dorsal recruitment without ventral overdistension. So as we found that after setting the PEEP to 14, the PF ratio improves from 120 to 180. The driving pressure drops from 20 to 15. There is no hemodynamic stability, and we move ahead with the patient's ventilatory strategy. Let us come to a second case to highlight one more emerging aspect of ARDS ventilation. A 36-year-old male develops aspiration-related severe ARDS. A patient is on this one ventilator setting of volume control with a lung protective ventilation at tidal volume of 6 mils per kg of predicted body weight, PEEP of 14, respiratory rate of 28, FiO2 of 0.8, with a plateau pressure limit set at 32, driving pressure of 18, static compliance of 23 mils per centimeter of water. The ABG shows a pH of 7.12, PCO2 of 85, PO2 of 72. Now, the problem is that further reducing tidal volume to lower the driving pressure will worsen this severe hypercapnia and acidosis, and increasing the respiratory rate will worsen mechanical power and will also cause ventilator-induced lung injury. Now, in such situation, the emerging concept of ECOR becomes relevant. So ECOR is extracorporeal carbon dioxide limited in the removal, where a low flow extracorporeal system, 0.4 to 1 liters per minute of blood flow, that removes carbon dioxide more efficiently than it can remove oxygen or deliver oxygen. See, as you can see on your left, which performs the key functions, that it clears 20 to 50% of the CO2 production and permits significant reduction in tidal volume, respiratory rate, mechanical power, driving pressure, as well as the plateau pressure. Now, how to initiate ECOD in this patient? We have to initiate when there is severe hypercapnia with a PCO2 of more than 70, pH is falling less than 7.2 despite lung protective measures, with a driving pressure of more than 15, plateau of more than 30, high respiratory rate of more than 30 causing elevated mechanical power, and no immediate need for full ECMO oxygenation support. So if you look into this, our patient meets all these criteria. So we technically set up cannulation, typically a right femoral vein, double lumen, either 15F to 90F, and we use a blood flow of 350 to 450 mils per minute, a sweep gas of flow of 4 to 10 liters per minute. And once we start, we expect the physiological benefits like a reduction in the strain and stress, reduction in the energy load, so leading to a less of incidence of villi, reduced cyclic alveolar opening and closing, reduced volute trauma, barotrauma, atelectrauma, improved pH via extracorporeal CO2 removal, and right ventricular unloading from decreased hypercapnia. So if you look into this ventilatory adjustments after record, which is applying the ultra protective strategy, parameters. The tidal volume, which was 6 mils per kg before, can be reduced to 3 to 4 mils per kg. It was reduced. The respiratory rate comes down from 28 to 10 to 18. The plateau pressure comes from 32 to below 28. The driving pressure comes down from 18 to below 10 to 12. The mechanical power, which was high, becomes very low. So before ECOR, 1 to 2 hours, before ECOR, the pH was 7.12. After 2 hours, it becomes 7.22. 6 to 12 hours later, after full ultraprotective ventilation, it reaches normal 7.3 to 7.35, with again the PCO2 coming down from 85 to 60 and then to 45 to 5. So without ECOR, ultraprotective ventilation is dangerous because this hypercapnia can be dangerous. So this is also an emerging concept. The one we have to note that there are certain differences between ECOR and ECMO because the blood flow is much lower in ECOR in comparison to ECMO. The oxygenation support is minimal. It is used in cases of hypercapnia as well with driving pressure reduction, whereas ECMO is used in severe hypoxemia. The cannulas are smaller here, between 13 to 19 French, whereas in ECMO we need larger cannulas of 21 to 25 French. So in our case, the patient had a pH of 85, 7.12 PCO2 of 85, which was ideal for the ECOR support. So ECOR is one of the emerging concepts of ARDS ventilation. Coming to the third case, a 54-year-old man with septic ARDS has been on volume control ventilation for 7 days due to ventilator dysynchrony and oxygenation failure. Currently, patient is having a PEEP of 12, FiO2 of 0.5, tidal volume at 6 mils per kg, respiratory rate of 26, plateau pressure of 26, driving pressure of 14. Patient is sedated with propofol as well as fentanyl infusions, atracurame infusions used intermittently in the first 48 hours. The diaphragm ultrasound shows a fractional thickening of 12%, which is reduced. The diaphragm thickness decreased from 2.1 millimeter to 1.7 millimeter over 7 days. Now, this patient is having ventilatory induced diaphragmatic dysfunction, and as a result, we can see that is now difficult to wean. Now, using this practice of NAVA or proportional assist ventilation is emerging as the best practice in such cases. NAVA uses diaphragmatic EMG, DDI signal, which for strong effort it increases the support, which weak effort justifies decreases in the support and maintains effort in the safe zone. It prevents both apnea and overloading, improves synchrony, so there is no trigger or cycle issues, and it is excellent for prolonged ARDS ventilation. The proportional assisted ventilation supports patient effort as a percentage of demand, so 40 to 70% of support is recommended, and the aim is to provide a tidal volume at 4 to 8 mils per kg. The FDI thickening of within 15 to 30% and a closing volume of 1.5 to 4 liters. And at that, if we look, we will prevent diaphragm atrophy, reduces work of breathing, reduces asynchrony, and is safer than pure pressure support ventilation. So this approach is called integrated lung diaphragm protective ventilation. So from lung protective ventilation alone, the emerging practice is lung diaphragm protective ventilation, so to reduce the thickening of the diaphragm. So applying to our case, our patient has a fractional thickening of 12%, so there is diaphragm disuse, stable oxygenation, so it is ready for assisted ventilation, no major asynchrony currently, and no contraindication to spontaneous effort. So when we use the proportional assist ventilation, we set the percentage assist to 40% and titrate up to 60%, aiming for a tidal volume of 4 to 8 mils per kg between a respiratory rate of 18 to 25. The PO1, that is closing volume, between 1.5 to 4. The TFDI support of 15 to 30%. Avoid over support of TFDI of less than 10 and avoid under support with a TFDI of more than 40. So this produces balanced effort, improved synchrony, and improved weaning trajectory. So objective monitoring after mode switch, we can see that the thickness improves from 1.7 millimeter to 1.9. the percentage of fractional thickness also improves. The P over 1 closing volume improves and the sedation requirement becomes low. And this pattern shows recovery of the diaphragm activity. So my take home message is that for ARDS, we have to think now of precision ventilation and not protocolized ventilation. We use dynamic bedside parameters, the driving pressure, the mechanical power, and the electrical impedance tomography to guide real-time adjustments. The EIT-guided PEEP titration individualizes the ventilator settings in ARDS and protects. There is need to protect both lungs and the diaphragm and prevent ventilator-induced diaphragmatic dysfunction. So ultra-protective ventilation and ECOR gives a total lung rest strategy, and this concept is an emerging cornerstone of precision ARDS ventilation. And also, combined physiology, technology, and personalization is most important for optimal ARDS care. Thank you.